Okay, we are live. You can proceed, Dr. Itzas. I'm muting myself, but I'm here if you need any help or if the session needs any moderation.
Okay, thank you. And sorry for a little bit late because I was surrounded by my kids, so that's why I'm 5 minutes late. And for some slides has been deleted. That's why I was making a little bit busy. It, so sorry for that. Yesterday we have completed middle and suboccipital approach to assess the lower part of the medulla oblongata, that how we have to approach. Later on that we uh, ended at this point that today we will conclude the upper part of the medulla by the help of Telovelar approach. So till that here we are at the level of suboccipital surface, and we have opened the posterior part of the posterior cranial cavity, the lower medulla oblongata, and the suboccipital surface of this one that is visualized. When we open the suboccipital surface, actually cerebellum has the three surfaces usually according to the approaches. If we are approaching the suboccipital midline craniectomy, the cerebellar surface will be suboccipital surface. If we are going to the tentorial approach, the cerebellar surface will be the tentorial surface. If we are approaching the CP angle, the cerebellum approach will be the petrous approach of this one. So when we are just opening, we have opened the arachnoid, we have peeled the arachnoid. After peeling the arachnoid, this kind of a picture will be in front of us. We are approaching to the, you can say the uh, uh, Telovelar approach. So this is the suboccipital surface. This bilaterally you can see it is the horizontal fissure that divides into the superior and the inferior part, inferior portion. And these both are the tonsils. Here will be the pica. This is the cerebellar. This is the inferior cerebellar peduncle will be there, and this is the lower part of the medulla oblongata. Uh, this is the macula. What is macula? Yes, please. What is the macula? Yes, anyone? What is the macula? No one is there who can tell that what is the macula. Okay, actually the macula is the area where our, like the fox cerebri, our area, all the dura is attached here. That's why it's called the macula, or you can say the sinus is attached here. So these both are the tonsils. These are the tonsils. And now what happens actually, and this is the same picture, just we are going above to this, the occipital, suboccipital surface. We can see the vermis of the suboccipital area. Vermis has how many lobules? How many lobules of the vermian?
So 9?
Yes, 9. Can you name, please?
Yes, sir. Sir, folium, tuber, pyramid, and folium, tuber, pyramid. Sorry, sir, I forgot.
क्या हुआ? चलिए बताता हूँ. These are the suboccipital surface, and in front of you, that's why you're memorizing it. Look at here, this is the last one, that is the uvula. Okay, and here will be the last one inside. We will dissect this tonsils, we can find the nodule. Okay, so these are the 5 lobules here: folium, tuber, pyramid, uvula, and the nodule. What about the remaining 4? Anyone else? Any other person? Yes. Yes, please. No? What about
Doctor? I'll try.
Yes, yes.
Anterior lobe, there is lingula, central lobule, culmen, and then in posterior there's declive, folium, tuber, pyramid, and uvula.
Excellent, excellent. Those 4 are at the level of the tentorial surface, and these 5 are at the level of suboccipital surface. So these are the 5 lobules of the vermion. So we are not concerned with this, but we should know about the detailed anatomy while we are dealing with the suboccipital surface of the cerebellum and the posterior fossa. So this will be our target to approach this one. As we open it bilaterally, we can see the tonsils, lower medulla, this is the pica above side from here, and there's the macula, inferior cerebral peduncle, and lower part of the suboccipital surface, inferior portion of the suboccipital hemisphere. Okay, so after that, what happens usually if we retract the tonsils. Tonsils should be retracted bilaterally, and on the lateral side to see 2 areas. One is the inferior medullary velum that we should know, and second is the tila choroida. That's why these 2 are very important to know, because now here at this here on the left side you can see that tonsil has been resected to realize. On the right side, the tonsil is there, but on the left side, you can see the tonsils is not there. Just to know that how the normal anatomy is there. When we resect the tonsils here, this thin membrane, look at here, this thin membrane from here to here. This is the inferior medullary velum. Okay, this is inferior medullary velum, and here, can you see this junction?
Yes, sir.
Yes, please, can you see?
Yes,
This
sir.
is the junction here. Okay, this is the junction. This is the inferior medullary velum, and this is the tila choroida. This junction is actually called the telovelar junction. This junction is called telovelar junction. Just we can, when we go back at the level of this one, just medially there will be the foramen majendi, and just posteriorly the choroid plexus and Dr. Yusra, please mute yourself. Thank you. Just posterior lateral to the tila, we will see that the choroid plexus, and laterally, more laterally, when at the level of, you can say the medulla oblongata, laterally we will see the follicular part of the, you can see the cerebellum. Okay, so this is the part, our target will be here. And this picture on the right side, the D1, bilaterally we have resected the medulla, the tonsils to see bilateral pictures. You can see easily the inferior medullary velum, the tila, this is the inferior peduncle, the choroid plexus. Okay, and this is the nerve, cranial nerve. Which nerve is this one? Yes, please.
12th.
12th, good. So here is the junction. Look at here. It is mentioned here that is telovelar junction. So our target is that we have to open this junction, and as we open it, we will be inside the 4th ventricle. And 4th ventricle actually, when we reach the 4th ventricle, it means we have reached the floor of the 4th ventricle. That is the lower part of the floor of 4th ventricle is formed by medulla oblongata. Upper part of the medulla oblongata. Till that clear?
Yes, sir.
So this is the cadaveric picture of same anatomy we have done. That tonsils, we have to retract these tonsils. This is the pica, and this is 9th cranial. This is C1, the root of the C1 above here with 12, and this is the dentate ligament will be here. In the far lateral approach, we will see we have to retract this dentate ligament. How? After this one, when we see we have resected this the tonsils bilaterally, and here it is retracted, and here it has been resected. Some part of the vermis is being shown here. This is the inferior medullary velum, and this is the 4th ventricle. You can see here clearly. When you see the fourth ventricle, now it is easy for you to see the upper part of the medulla oblongata. Can you see, please? Yes or no?
Yes, sir.
Look at here. You can easily see and appreciate the upper part of the medulla oblongata. This is what? This midline. Yes, please.
Posterior median sulcus.
Posterior median sulcus. And upper part of the medulla oblongata, we have discussed that it has three
triangles.
It has three triangles, yes or no?
Yes.
So what kind of triangles? Three?
Hypoglossal, vagal, and area postrema.
Very good. So upper medulla we can appreciate here. And when we are approaching here, look at here, this one very easily, very good view of this one on the other side. Now we know that our safe entry zone is entry zone of the of the medulla oblongata, upper medulla oblongata is posterior median sulcus if the tumor is midline. As we are going through the suboccipital approach, our target is midline lesion, either the lower part of the medulla, or the upper part of the medulla. In both situations, our target is to approach the midline lesion or little bit just lateral lip of the medulla oblongata. The lesion is there. We can approach this one easily. We will open this, dissect this posterior median sulcus, and whatever the lesion is, we try to take the biopsy. If the glioma is there, we will try to get the biopsy. If there is a cavernoma, most likely there is a good chances that we can dissect the cavernoma totally, and it has the good results. So this was the brief some overview of the Telovelar approach and upper medulla oblongata. Our next approach is a bit tricky, and we should know about it. So that is the suboccipital lateral and far lateral approach. Suboccipital lateral and far lateral approach is for the lesions of anterior-lateral lesions, or some extended very huge lesion is there. Most likely anterior component association is there. We will go for the suboccipital far lateral approach, but it has a lot of and great nomenclature. It has a lot of variations, and look at here. There's a long list of the lateral approaches when you are going suboccipital. Actually, these approaches are suboccipit. Then we divide according to the area, that which area is appropriate and what is the lesion inside of the lesion is. We have to choose that approach accordingly. Lateral suboccipital, far lateral suboccipital, transcondylar, far lateral transcondylar, far lateral transcondylar, transtubercular, extreme lateral transcondylar, extreme lateral craniocervical, extreme lateral inferior transcondylar. We will go inferiorly from the condylar occipital condyle. So these all approaches are included, you can see, in the lateral and far lateral suboccipital approaches. But it doesn't mean that we have to know and we have to do all these kind of approaches. What are the good one and what is the appropriate? We have to do that. But one should know that what is the lateral approaches. It is good for the knowledge, but not for the practice. So far lateral, what will be our target and what will be the scheme of this far lateral approach? Lateral suboccipital retrosigmoid craniectomy we will do from the retrosigmoid area, occipital area to the foramen magnum. We can do plus minus C1 hemilaminectomy at the ipsilateral side. We will do the partial resection of occipital condyle. We'll do the craniectomy, and that craniectomy depends upon the location and pathology of the lesion. What is the size of the lesion? If the lesion is huge one, we can resect the occipital condyle completely, or we can do the hemilemectomy of C1 and then C2 also, and we can do also the suboccipital craniectomy, large one, but it depends. So degree of bone removal depends on the size and location of the pathology. What are the indications? You all know very well that what are the indication of these one. I will not just go through this one. Foramen magnum, upper cervical meningiomas, schwannoma, chordoma, chondrosarcoma, aneurysms. The posterior circulation aneurysms can be approached and in a good way by this approach, far lateral and the lateral suboccipital transcondylar. Cavernomas located anterolateral brainstem, anterolateral neoplastic lesions, upper spinal cord, anterior pathology can be approached with the help of this approach at the level of cervical level spinal cord lesions. So what is the position of this one? Usually we prefer the position of park bench or 3/4 oblique position. You know very well that how to do this position, that our head size will be little bit, it is a neutral position. There will be no flexion and little bit elevation of the head should be there to need some exposure, because we know when intraoperatively we will see that what kind of hurdles could be there. That's why this position is very important. There is in the lower one figure, the skin incision has been marked here. There are many thoughts of the surgeons. One incision is the C shape that start from the above pre-sigmoid area and go downward till that the neck at the level of C1, C2. This is the one incision. Some surgeons prefer this one, but usually the standard incision is not like that. Standard incision is a horseshoe shape, inverted U shape incision that covers the both areas, the suboccipital as well as the level of the foramen magnum, cranial-vertebral junction, and C1, C2. So that will be the standard incision. This is the position again, and this is the second incision, that is the standard incision. You can do the inverted hockey shape, you can say, or some surgeons also prefer some U-shaped incision like that. Look at here. It starts from here, then above, then downward. So it's up to you that which incision, but usually this incision is very good. This one, both incisions, inverted U or hockey stick. This one, because it give more exposure. You can retract the skin flap lower downward easily, and you will not feel any hurdle while doing exposure to the normal anatomy. So that's why most of the surgeons prefer this incision. This is again incision, accurate, neutral. You can see the anatomy. This is the transverse sinus. We can give the incision just above the transverse sinus, but our craniectomy will be below to this one, and start from the nuchal line, then go upward, frontal, lateral, then at the midline, just come to the midline at C1, C2. Till that C2, you can give the incision most likely. But if the lesion at the below one side, also at the level of C1 and C2, so we can do, we can proceed till further up to the level of C3. So these are the some landmarks. The laterally, the incision should be at the level of asterion, and the laterally at the level of lower level, it should be at the mastoid area, just above the transverse sinus. Medially, it should be at the level of anion, not should cross this one, and downward at the level of C2. These are the some landmarks of incision laterally and medially. This is some views of approaches about the posterior fossa, or you can say the brainstem, suboccipit, far lateral. the suboccipit, midline lesion, far lateral, anterior lateral lesion, retrosigmoid approach, CP angle, and then till that petroclival area. The transpetrosal approach is the excellent approach. We can simultaneously we can appreciate the lesion of the middle fossa, as well as we can cross from the petrous part, anterior petrosectomy. With the help of anterior petrosectomy, we can approach the petroclival lesions, and at the level of also the anterior part of the medulla oblongata can be approached through this one level. Some temporal area, subtemporal approach, and combined supra and infratentorial approach can be approached through this one. These are the multiple approaches. It depends on the size and site of the lesion, that where it is, then we will choose accordingly. So I missed the craniectomy. I think my kids has deleted some slides, so that's why I missed some slides. So I'm sorry for that. So when we are doing that one, look at here. After doing the incision, our burr holes like same area will be placed just medially to this one and here. And this hole will be the craniotomy. This hole will be the craniotomy. Okay, we have to see the sigmoid sinus, and as we approach intraoperatively, the sigmoid sinus is a little bit deviated here, so we have to be careful about that and just thinning out that bone, and then we can mobile the sigmoid sinus. If we feel that operatively we have some hurdles, there is some difficulty and in the vision, then we can mobilize the sigmoid sinus as well after opening of the dura and mobilization of the sigmoid sinus. Oh. So suppose that we have done the dura. Dura will be open in the same manner as we have gone through the, you can say, the skin flap. I want to show you another picture, that suppose that if we have done this skin flap has been done and is split retracted downward, then there is a myofascial plan is very important. Here there are two types of muscles. One is the superficial one, and someone is the deep muscles are there. We should know that superficial muscles and deep muscles, that how to dissect that. We have to, when we are dissecting these muscles, superficial and deep, we have to retract it downward or little bit. If lateral muscles are there, we have to incise them and dissect it with the help of periosteum. We have to lateralize them. Lateral muscles are there. Like what are the muscles are there? Medially will be the trapezius muscles, semi-capitis muscles will be there, and the sternocleidomastoid muscles will be there. So we have to be careful about that, the myofascial plan, after taking the skin incision and approaching to the bone. We have completed the dura. Suppose that we have completed the dura and we have opened the dura in the same fashion. And one thing that I want to show you that is not here. Sorry. When we have opened the dura, now there is an important structure, that is the occipital condyles are there. Because at the level of this one craniovertebral junction, what structures are important? What critical structures are there? at the level of C1 and craniovertebral junction. Suppose that here.
Vertebral artery, sir.
Excellent. Vertebral artery. Mustafa, which part of the vertebral artery?
Sir, C3, V3, sir, V3.
Excellent. How V3 can, how V3, what is the course of V3? Yes, very good.
Yes.
V3.
V3, sir, from the C2 to the foramen magnum, sir.
You are right. Excellent, Mustafa. But I am saying that what is the course? How it travels?
Sir, sulcus arteriosus, which is present on the upper surface of the first vertebra, atlas.
Excellent. Excellent. You have to be careful about this one. I have missed that slides. That were very excellent slides. So when C3 just come here, Mustafa is right. Dr. Mustafa is right. It goes like that. That goes like that. Am I right? Dr. Mustafa, am I right? So
yes, sir. Yes, sir.
This is the course. This is the course of V3. This is the course of V3 just at the level of C1, and there is a junctions there that traverses through that one. Very important. This is the J shape. Look at here. This is J shape. So remember that one. That the posterior arch of the C1 is very important because the vertebral artery is there. When we are hemilaminectomy, we are doing the hemilaminectomy of C1. We should be careful about that. But when one thing that is important, most of the time it is not that vertebral artery can be damaged. How? Because when vertebral artery comes here, when it comes here, it will go like that. Okay?
It says, I'm sorry to interrupt you. I have shared the image in the chat box. You can open it. See if you can open it. Just so that it would make your teaching a bit easier. Can you open it?
No.
No?
Unable to open it.
Achha, is the chat box accessible?
Yes. 1 minute, please. Yes.
If you want to see one image, I can share my screen for a minute and then you can let me know when you want to share your screen again. Is that okay?
Okay, it's visible now. Is it visible?
No, sir.
Is it not visible to all of you?
No, sir.
So can Dr. Kawal, can you share your screen, please?
Yeah, I can share my screen and then you can let me know when you want to turn it off. Just give me a minute. Okay, so is this visible?
Yes, ma'am. Yes.
Now it's visible.
Yes, sir. Yes, sir.
This arrow is visible. What it is moving?
Which
yes,
arrow?
sir. Yes, sir. The cursor is also visible, sir.
Visible? Okay.
Yes, sir.
Thank you. So thank you, Dr. Kamal. आप मुश्किल कुशा हो गई हैं मेरे लिए.
Thank you so much. You keep
So look at
reverting back to Urdu during the session. I think you missed teaching in Urdu.
Look at here. This is vertebral artery. Look the course of the vertebral artery when it comes at the level of C1. So this is the course. This is kind of a J shaped here. Then it goes upward bilaterally till the medulla oblongata. Then it combines and met the basilar artery. So how we can avoid this vertebral artery? It's very easy, quite easy. Most of the time, vertebral artery, this anatomy is same, like the 85 to 90% of the people that have the same course of the vertebral artery anatomy. But little bit there is a variation, 5 to 10% variation is there. So when it comes more medially, then it will be difficult for us to tackle this one. Suppose that you see that this is the C1, this is the C1, this is the ganglion or C1. Okay, here will be the posterior arch of the C1 is there. So what happens when you are giving the incision for the durotomy, you are doing the durotomy, just go a little bit medially like that. Okay. Like that. Okay. Above. Suppose that, and this incision will be like that in the dura. In same manner, while we are taking the skin flap and this one. So little bit medially, just we know that what is the landmark of C1 arch at the medial side, we have to be little bit medial. Then it will be easy for us that we will not go through this one. Okay, but suppose that it's not possible, then what happened? We will do hemilaminectomy of C1. Then we have to little bit mobilize this C1 root, posterior arch of the C1 will be taken out, ronged, and then with the help of there will be the dura has been opened. We have to peel the arachnoid. You have to mobilize this one, the vertebral artery, little bit laterally, but very in a good manner. That will be easy for you. If we cannot avoid this vertebral artery, it comes in our anatomical side and the surgical side, then it is mobilized easily. Got it? Any question? Up to here, any question?
No, sir.
I have another picture. Let me share that one. That would give a better idea in terms of and the anatomy. Just give me a minute.
I put it that that cadaveric picture, real that one, but I missed.
That's okay. Things happen. We have kids. Just give me a minute. I'll open that and maybe you can go over that one again. Okay, so the quality is not good, but I think it would work. Just a minute. So is my screen visible? No, I think I would need to share it again. Just give me a minute. Does this work fine?
No.
Yes, it shows the far lateral approach.
Dr. Itzaz, is my screen visible?
To me, it's not visualized.
Okay, I think you're seeing your screen. Let me see why. It's visible to everyone else.
But it's not visible to me.
Okay. Okay, that's okay. We can just continue with your screen. I'd stop sharing. I'd stop sharing and then you can share yours. That's okay. So is Dr. Itzaz's screen visible to everyone else?
Yes.
Okay. We can proceed.
I missed because two slides that were very important, that how to we have to tackle and how to mobilize the vertebral artery and how to first we have to avoid the vertebral artery. We usually by the opening the dura. If it's not possible, then how we have to mobilize the vertebral artery, how we have to rupture the posterior arch in hemilaminectomy. There are two areas. One is the level of hemilaminectomy while doing, and second point is there when at the level of you can say this is the rim of the foramen magnum that has been cut down, and the level of this is the level of you can say the junction will be here. Craniovertebral junction. This will be the craniovertebral junction, and here will be the occipital condyle will be there. If there is a occipital condyle is there, we have to partially resect that occipital condyle most of the time, because it gives some notch medially, the medial part of the occipital condyle. Suppose that here is the occipital condyle. Suppose that here is the occipital condyle. Suppose that this one is the occipital condyle. So we have to resect that occipital medial part of this one, that is called the partially resected, because it gives some anatomical hurdles when we are going through inside it. And when once it has been done and you have opened the craniovertebral junction, now in front of you the anatomy and all the structures are visualized, and you have to know the detailed anatomy. Look at here, this picture. This is not cadaveric picture. Cadaveric picture actually are real and good one to understand. That is very similar to the surgical approaches, surgical exposure as well. So anyways, when you will open the lateral part of the far lateral approach at the level of craniovertebral junction, this kind of a picture will be in front of us. Okay, look at here. These all are the pictures. Till that here, this is the spinal cord at the level here, but at above the level of the foramen magnum, this is the medulla oblongata lower part. Our target is here, the lateral side. Look at here. This is not clear, but this is the junction. That is a safe entry zone. Which safe entry zone will be here at this level? Which safe entry zone will be here? Yes, please.
Posterior lateral sulcus.
Very good. Posterior lateral sulcus. Why Dr. Sana is always there when I ask question? So it's good she's there, but others should also participate. It is just a revision, and also I will be fresh when I will do. So this is the posterior lateral sulcus, is the lateral aspect of this one, because we know that for lateral approach is for the lateral aspect as well as the anterior aspect. This is not pure the position of the patient when it will be there. When we will lateralize patient, past bank position, simultaneously it will be very easy for us to directly we will target the lateral side when the patient is at the level of the park bench. The directly we will vertically 90 degree, when we will target, our target will be 90 degree, directly we will hit the posterior lateral sulcus. But simultaneously, we are also visualizing the anterior part of this one till that the front. If you go upward, we can see upward. But you should know the structures of this one. Very important. I will make the triangle. If you are going lower one and above one, then you should know a triangle. That is very important. So this makes a triangle. Look at here. Yes. What is this triangle? Yes, please.
Hypoglossal
Yes.
triangle.
Hypoglossal triangle is there, but this is not medulla oblongata. Dr. Sana, you are there. So this is not medulla oblongata. This is the lateral aspect. Through this triangle, we will enter to the anterior side. This is what? This is the hypoglossal nerve. This one. This is which nerve?
Spinal
This is 11th.
accessory nerve.
Spinal accessory nerve. It has two parts. Okay. And what about this nerve? This is vagus nerve. So actually, the triangle is being formed with the help of two nerves. On the lateral side and the medial side, there is a vertebral artery, and inside there is a 12th nerve. So the parts which is being formed by the 10th nerve and the 11th one nerve. That's why this triangle is called, it's known as vago accessory triangle. Yes, please.
Okay, sir. Vago accessory triangle.
Yes. So vago accessory triangle. This is a triangle by with the help of this triangle we can enter inside and approach anteriorly. Another side is there, just lower part of the medulla oblongata at the level of 11th nerve. This is the 11th nerve. You have to mobilize this vertebral artery little bit laterally. Then this area, it will be the huge area over there, and you can approach the medulla oblongata when we are doing at the level of most lower part of the medulla oblongata. First, this triangle, you should know this is the important. The vago accessory triangle is very important when you are approaching the medulla oblongata anterior part, and through lower part when there is a just crossing, the 11th nerve is crossing just over the vertebral artery. We have to mobilize and retract the vertebral artery a little bit laterally after peeling the arachnoid over there. Then it will be easy to lateralize it gently. Then we can make a safe entry zone here, and then we can enter in front of it. So got it till that here? Any confusion?
No, sir.
So this is again a picture of the cadaveric view. That is, you can see easily that how we have to approach this one. Anyone who can interpret this one? Yes, please. Anyone? No? So look at it. It's very easy. This is the medulla oblongata. This is pica, that's upper portion. This is the lateral area. This lateral area is there. And this junction is there that we can see. This is the pons. Look at here. This is pons. This bulge part, this is pons. Okay. This bulge part is pons. The pontolum, this is written here. Pontomedullary junction is here. So this is the upper part of the medulla. This is the lower part of the medulla oblongata. When we see laterally, it is quite easily visible. This is bulge. This first bulge is here. This is first bulge. And this is sulcus. This is sulcus. Which sulcus is this one?
Lateral sulcus.
Posterolateral sulcus.
Posterior sulcus. And what about this one?
The inferior cerebellar peduncle.
What about this portion?
The second
Inferior,
bulge.
inferior
Yes,
cerebellar
please.
peduncle.
Yes.
Inferior cerebellar peduncle.
How inferior cerebral peduncle will not be here. This is the superior part. It will be little bit downward. This one. It will not be here. Inferior cerebellar peduncle will not be here. This is the medulla oblongata, and it is written. It is olive nucleus. It is the anterior surface of this one. When we'll see I think when we memorize and remember the anatomy of the cerebellum, it is very important that it is the conical shape, a little bit cylindrical. Anteriorly, there is and it is a very rotatory one. When you will see the medulla oblongata and real, it is very rotatory. Just anteriorly, there is a pyramid. Laterally, and that is a posterior laterally. Actually, there is the olive, and that posterior lateral to olive, there is a posterior lateral sulcus, and just behind most dorsal part of this one will be the posterior surface of medulla oblongata. Upper level, medially there will be the gracilis, and laterally there will be the cuneatus. So you shouldn't be confused in this one, that if we are visualizing posteriorly, how it is possible that the olive is there. We are not visualizing posteriorly. We are not approaching posteriorly. Actually, we are approaching anterior, posterior laterally. That is the far lateral approach. So that's why this olive is visualized here. So this is the olive. And this is our target will be there. If we are going through this one, that's the posterior lateral sulcus, and very good approach. If we are doing the posterior approach, that is the posterior median sulcus. If we'll go anterior side, then you have to make the you can say the safe entry zones of this one. Very easy. Previously, we know the 10th nerve is little bit downward, so it is not shown here. Otherwise, that is the, look at here, this area. This is the 12th nerve. This is the vertebral artery will be here. And just is come around, it will make the pica. Look at the course, typical course of this one. And this is the sap entry zones, which we previously discussed, that it is found by the vago-hypoglossal trunk, hypoglossal triangle. It is a little bit downward. This is the content of this vago-accessory triangle, that is the 12th nerve. So you should be clear about that. This is the olive. Okay. Are you clear?
Yes, sir. Clear.
Yes, thank you.
So this is the far lateral approach. This is lateral or far lateral approach of the suboccipital craniectomy. With the help of this one, we can approach the anterolateral and the lateral aspect of the medulla oblongata, invertebral reduction, and up to the lower part of the pontine anterior areas of this one. Will that hear any question, please? Look at this picture. It's the same one. Look at here. This is a triangle. This one, which I told previously. This is the triangle. Look at this one. This is the triangle. This is the pica. Lower part will be have the vertebral artery, and upper part will be the pica if you are going upward. And this is the content. This is the 12th nerve. This is 11th nerve that is going downward. It has two components. This is the these long fibers are there of the of the 10th nerve. So this is the triangle. With the help of this triangle, you will enter lower part. You have to retract that vertebral artery, and upper part it will contains the pica. So this is the actually vago-accessory triangle. So this is all about lateral and far lateral approach. Some slide I have missed, that is about that how we have to Roger, how we have to take out the condyle, that is occipital condyle, how I have to mobilize the vertebral artery, and how we take the laminectomy of the C1, and how we have to make the myofascial plan of the superficial and deep muscles. So in the next one, when we will discuss the next approaches, I will try to review it within 5 minutes. Till that, here, any question, you are welcome. Yes, please.
Dr. Sana is asking that what would you prefer as a reference book for surgeries?
What books I refer? First, go to the Rotan. It is very excellent, and minimal, some surgical touch has been given there, Rotan's anatomy. And secondly, operative cranial neurosurgery anatomy is very good. You have to go through that one for the basics. And then there is some long book is there, that is the principle of neurosurgery. So these are 4 books. But if you are going from the beginning, Rotan, then the operative key and neurosurgery anatomy, and then the principles of neurosurgery. So these are the books that I follow.
I just wanted to give a small advice in terms of, because I know why they are asking. A few of them are exam candidates, and you
Okay.
referring them to Rotan would, I think it would give them a hypoglycemic shock. So there is another book which is a short book, Tricks and Trade of Cranial Surgery, or something like that. There is one for spine and one for brain. It's a very good short book in terms of getting a rough idea of the surgeries, because you cannot get a hang of these surgeries until unless either you have assisted in these, or you have watched enough videos, or you have done such cases yourself. Otherwise you're going to have problems. So yes, operative cranial anatomy, I don't know the exact name, and then there's this tricks and trade. Let me see if I have those in PDF. I can always send it. And I'm sure Dr. Itzaz will review the far lateral approach tomorrow, inshallah, before we move on to the next approaches. Any questions, any feedback?
Thank you so much.
You are welcome.
Thank you,
Tomorrow
Dr.
we'll do
Itzaz. Thank you, Dr. Kaval.
Thank you. Thank you.
Thank you
And
so
you are
much.
welcome every time, anytime.
And by the way, Rotan is a beautiful book. So
Yes.
even
Thank
if
you.
even if you have cleared the exam, or you can find some time to make it as a coffee table reading, something that you do just for the sake of, for the love of neurosurgery. So Rotan is a beautiful, beautiful book. That's it, I
Yes, no
think.
doubt. Britain is good one.
Okay,
Yes, we have
everyone.
to conclude it.
Yeah, so that's a wrap
Thank
for
you
today.
so much for
Why,
the session.
why they
Thank you.
are why they are silent, so silent?
I have no idea why they are so silent. I think they're slightly scared of you. They have gotten very comfortable with me.
Why?
I have no
Because of
idea why they're so
fasting.
silent.
Dr.
Sorry?
Itzaz, we are all fasting, so that's why we are
Oh,
hypoglycemic.
okay. So that would get better with Ramzan, inshallah. And yes, you have to revise more. Yes, Dr. Lalita is saying that she needs to revise more. We all need to. It's all
Yes, yes.
volatile.
Tomorrow we will give some review of about the far lateral approach. Then we will proceed the petrosal, and then we will anterior approach, typical anterior approach, that is the nasal transspinatal approach.
Okay, so that's a wrap for today. Thank you so much for attending. Thank you, Dr. Itzaz, for taking out the time.
Thank you. Thank you.
I'll upload the recording after, maybe I'll briefly edit and then upload, or maybe I'll just share the link for the live stream. That's it for today. Leave feedback, questions, anything that you want to say on the group. Thank you so much. Dr. Lalita, I notice your heart. This is the second one. Thank you.